In this presentation today, we're going to cover ventricular dysrhythmias or ventricular rhythms. We're going to cover the premature ventricular complex, the idioventricular rhythm, the accelerated idioventricular rhythm, the ventricular tachycardia, ventricular fibrillation, and asystole. Although asystole is not a ventricular dysrhythmia, I like to cover it in this chapter anyway because asystole doesn't really fit into any other presentation. When we talk about ventricular rhythms, of course they originate in the ventricle, but they also depolarize and contract asymmetrically and out of sync. Potentially this could cause a drop in the cardiac output. It is also the result of the failure of the atria and the AV junction to initiate a beat. So when we're talking about that, what we're talking about is the tertiary pacemaker system in the heart, which is the Purkinje network. The ventricular rhythms could also be the result of increased automaticity as well. So real quick, before we get started, what is the failsafe if the SA node fails to fire? Well, in that case, it would be the AV node. The AV node is the backup to the SA node, so the AV node is the backup pacemaker. Well, what happens if the AV node fails to fire? In that case, it would have to be the Purkinje network or the Purkinje fibers. If the Purkinje fibers fail in the ventricles, what happens if the ventricles fail to fire? Well, basically you go into asystole. You end up in a lethal arrhythmia. What exactly does a PVC or any real ventricular rhythm look like? Generally speaking, they are wide and bizarre looking waves. A lot of times the T waves will travel in the opposite direction of the R wave. P waves could possibly not be visible. I mean, it is possible that there could be no P waves in there because they are buried somewhere in that ventricular arrhythmia. QRS interval in the perfect world is always going to be greater than 0.12 second for a ventricular beat or complex or rhythm. One of the most difficult skills to develop in this area is how do you measure the QRS complex? And I get these questions a lot of times. I have specific homeworks to make sure we teach how to measure the QRS properly. It's difficult to do it in one lead sometimes, so what we will do is we will do a 12 lead, and generally speaking, usually we just measure the widest QRS, and that will give us the proper measurement of the QRS complex. So in this case, we're going to pretend that these here are the same leads. Here's V1, here's lead 2, and this is why it's important that you do a 12 lead on patients who have anomalies on their regular rhythm strip. You should do a 12 lead to get a better view of what's going on in the heart. In this case, if all you were looking at was lead 2, you can see here, and they're of course telling you what the width is of the QRS. They're telling you that this is 0.11 second, which would be considered a normal QRS width. Unfortunately, you have your R wave, which is traveling opposite of your T wave. Automatically, that should qualify this person to get a 12 lead. After doing the 12 lead, you see that the true width of the QRS complex is 0.16 second, which makes it wide. So in the perfect world, what should we do? We should always measure the widest QRS width, and that should be our true width of the QRS. Let's talk about premature ventricular complexes. Premature ventricular complexes come from an ectopic beat that interrupts the normal rhythm. Now, what do I mean by ectopic? If you remember what I meant by ectopic, this is a focus or an area usually outside of the normal conduction. system. So basically what that means is an ectopic beat that occurs outside of the normal conduction system and outside of the normal cardiac cycle. If it's premature, that means that it occurs early in the cardiac cycle before the next sinus beat. I have sinus beat, but it can occur before the next R wave. So it will occur early in the R to R interval. Usually it's caused by an increased automaticity. The increasing in the automaticity can occur from a couple different things. One of them is, the most common one, is just some kind of irritability in the ventricular wall. Some of the things that can cause irritability would be ischemia, could be hypoxia, it could even be damage, and usually this could come from like a blunt trauma. It could also come from just a sympathetic nervous system, a massive sympathetic stimulation. And stimulants would be another one. So it can come from a few different things. Another cause of a PVC could be a reentry phenomenon. And if you remember the reentry phenomenon, there are 3 criteria that qualify as a reentry phenomenon. And we will cover those again here in a bit. PVCs are significant for 2 reasons. There's a bunch of reasons, but we're going to stick with these 2 for right now. Number 1, they can precipitate a serious dysrhythmia. This is VTAC, that's VFib. If you're not familiar with those abbreviations, those are common abbreviations. Another problem with a PVC is that it can decrease cardiac output. Now what that means is you can have a person with a sinus beat and a PVC and a sinus beat and a PVC and a sinus beat and a PVC. These PVCs right here could be non-perfusing. If those PVCs are non-perfusing, you can cut your heart rate in half of what you're actually perfusing. Which means, let's say somebody has a heart rate of 90 beats per minute, but every other beat is a PVC, your perfusing heart rate is actually 45 beats per minute. Some problems with myocardial ischemia. Frequent PVCs come with myocardial ischemia. Multifocal PVCs, we'll talk about what those are. Early PVCs, which is called an R on T PVC, could also. And then groups of PVCs. We're going to talk about each one of these and why they're significant. Each one is more critical than the next. First, let's talk about R on T PVCs. When we say R on T PVCs, what we mean is the R wave of the PVC lands or initiates on the T wave of the previous complex. So what that means is if you look down here on this rhythm here, this appears to be a sinus rhythm. So as you come up to this point here, this here is all a sinus rhythm. So we have a P wave, we have a QRS, and a T wave. What is our heart rate? So 300, 150, 175. So we'll just pretend without doing the actual calculations and say that this is a heart rate of sinus rhythm at 80 beats per minute. Very normal. Now what happens is when you get down to this part right here, you then end up with a PVC that occurs on the downsloping part of that T wave. So if you look over here, this is the downslope of the T wave, here's the downslope of the T wave, and if you try to downslope the T wave, it doesn't quite make it all the way down before you have this PVC hit. What's happening is the PVC is hitting on the downsloping part of the of the T wave, which is the relative refractory period. I'm just going to abbreviate RP there. It's occurring on the downsloping of that T wave, which is the relative refractory period, which means it can respond to another impulse, but it is very delicate. In this case, this PVC that occurred on the downsloping part of the T wave right here caused the person to go into a VFib. Not all R on T PVCs cause a person to go into VFib, but that is a concern. Let's talk about a couple different types of PVCs. We have couplets. Couplets are pretty simple. We actually have 2 PVCs right here. We have a couple of them. We have 2 of them. That would be considered a couplet. Notice that the couplet morphology, look at the shape of these 2 PVCs. This would be considered a unifocal couplet of PVCs. The reason they're called unifocal is because the morphology is so similar here that they're more than likely they're coming from the same ectopic focus. What happens if they come from two separate ectopic foci? Then they would be multifocal couplet PVCs. Which one of those do you think would be worse? Well, the multifocal would be worse because now you have two ectopic foci in the ventricles that are irritated. Bigeminal PVCs. If they are bigeminal PVCs, that means that you have a normal beat here, so you have a sinus beat here and a PVC. Sinus beat, PVC. Sinus beat, PVC. Basically, that means that every other beat is a PVC. That makes them bigeminal PVCs. Let's look at the heart rate. Let's look at the ventricular rate of this rhythm. Let's pretend this is a 6-second strip. Our ventricular rate is 1, 2, 3, 4, 5, 6, 7, 8, 9. Our ventricular heart rate is 90 beats per minute on the monitor. Let's pretend that these PVCs are non-perfusing. What would be my pulse rate at, let's say, the radial? At the radial, my heart rate would be 45 beats per minute. That indicates a significant decrease in cardiac output and in tissue perfusion. Let's talk about trigeminal PVCs. Trigeminal PVCs is you have a normal beat or sinus beat and a sinus beat, and then you have a PVC. Sinus, sinus, PVC. And it could be any beat. It doesn't have to be a sinus, but I'm just showing you. You have two normal beats in a PVC, two normal beats in a PVC, two normal beats in a PVC. That tells me that every third complex is a PVC. That tells me that this person has a normal sinus rhythm with trigeminal PVCs. Is it possible to have four PVC every fourth beat? Of course it is. So we have a normal beat, normal beat, normal beat, PVC. Normal, 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 PVC. Normal, 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 PVC. The problem we run into with this, though, is that you probably have to have a pretty long rhythm strip to be able to identify a quadrigeminal PVC. So quadrigeminal PVCs means that you have a PVC every 4 beats, or more accurately, every 4 complexes. Let's interpret some rhythms. The blue dots that you see down here, when this book was put out, they put these blue dots down here to show you the normal R to R cardiac cycle. So this is where all the this is where all the QRSs occur. So that's what those blue dots are. But let's go ahead and interpret this rhythm right quick. What is my atrial rate? You can do it a couple ways. You can either do it the range like I talked about before, or you can do the 6-second method, or whatever you want. So let's go ahead and do the 6-second method just for time and simplicity. 1, 2, 3, 4, 5, 6, 7. So it's about 70 beats a minute. Let me just do the countdown. 300, 150, 175. So yeah, it's a little bit more than 70, but we'll just say it's about 70 beats per minute. What is my ventricular rate? 1, 2, 3, 4, 5, 6, 7, 8. So my ventricular rate is 80 beats per minute. Regularity is going to be irregular. P waves are present and married. Are they all present and married? No, they're not. They're present and married except at the PVC. The PR interval, look at the PR interval down here. How does it look? It actually looks pretty good to me here. So I'm going to say it's about 0.16 seconds. Like I said, I don't have calipers and I can't put them on my screen, so I'm guessing here. If you have a piece of paper, please use the proper process. QRS complex. Well, we have a couple different QRSs here. This isn't like before where the QRSs were almost identical all the way across. This is, now we have 2 different QRSs. So what is the QRS of our normal QRS right here? What is the width? We'll say 0.08 second. Now the problem we run into is we have another PVC. This one here isn't 0.08 second. This one is more like 0.16. 0.16 second. What is the overall interpretation of this rhythm? I will tell you now, the interpretation of this rhythm is not PVC. It's not that simple. So if you do that, it will be marked wrong. You have to put the underlying rhythm first. So the underlying rhythm is a sinus rhythm with, what do we have here? What is the anomaly? Unifocal PVC. That simple. You don't have to put unifocal. A lot of people do, but there's a ton of people that don't. There's probably more people that just put sinus rhythm with a PVC. On this rhythm, we're going to look at the atrial rate. 1, 2, 3, 4, 5, 6, 7, 8. Looks to be about 90. The ventricular rate, 1, 2, 3, 4, 5, 6, 7, 8, 9. You have to count the PVC, 10. Regularity. It has to be irregular because there's a PVC in there. P waves are present and married, except at the PVC. The PR interval, if we look at our PR interval down here, it looks to be about 0.12 second. The QRS complex looks almost a little bit wide, but I think it's okay. So 0.10 second. Looks like it's a little bit wider than 2 boxes, but not quite 3 boxes. My interpretation, underlying rhythm first, is a sinus rhythm. And then what's the anomaly? It's a unifocal PVC. The next rhythm we have here, let's go ahead and start with the atrial rate. As you can see, it looks like there's a couple PVCs in there. So what is our atrial rate? 1, 2, 3, 4, 5, 6, 7. So it looks like our atrial rate for this rhythm strip is 70 beats per minute. The ventricular rate, 1, 2, count the PVCs, 3, 4, 5, 6, 7, 8. It should be a 9, but we don't get a full QRS and T wave in here, so we're going to give it a half. So we'll say the heart rate is, the ventricular rate specifically, is 85 beats per minute. Regularity is going to be irregular. P waves, when you have P waves, they are present and married except at the PVCs. PR intervals, whenever you have PR intervals, they look to be a little bit wide, but they're still normal, 0.16 second. QRS complexes, well, the normal QRS, actually this looks almost a little bit wide, so maybe 0.12 second. The PVC, on the other hand, we're going to start here, we're going to end down here, so that looks like the PVC is 0.20 second. The underlying rhythm is going to be a sinus rhythm with unifocal PVCs. What I find interesting about this rhythm strip is that we have a PVC here, 1, 2, 3, 4, 5, and then a PVC here. I would like to see a longer strip to see if maybe we have a patterned PVC every 6 beats. If not, then we don't. We can just put unifocal PVCs. But if we do have a pattern, then we should identify that as well. In this rhythm here, clearly we have a whole bunch of PVCs that are occurring here. We're going to look at our atrial rate, which is 1, 2, 3, 4, 5. So we have a heart rate of 50 beats per minute. What is our ventricular rate? 1, 2, 3, 4, 5, 6, 7, 8, 9, and almost 9 right there. So we'll say 85 beats per minute because we don't have a total T wave right here. Regularity. This was a really good rhythm because technically the rhythm is irregular. But what I like about it is that the rhythm has a patterned irregularity. With the patterned irregularity, you can say that it is regularly irregular. What that means is it is irregular, but there's a pattern to the irregularity, so you could call it regularly irregular. I will also say in class, whenever you do your homework, if you just call this irregular, I'm not going to mark you off on it because technically it's irregular. The more accurate documentation, though, would be regularly irregular. P waves. When it has P waves, they are present and married, except at the PVCs. PR intervals, when we have a PR interval, we have a 1, 2, 3, about a 4, so 0.16 second. QRS complexes, the normal QRS complexes look to be about 1, 2.5, so 0.10 second. The PVCs, see how this PVC comes up and then it kind of doglegs up like that? That's the beginning right here. That's the beginning of the QRS complex. This would be a good ending of the QRS complex, so we're looking at about 0.12 second at the PVC. My underlying rhythm. Is my underlying rhythm going to be a sinus rhythm or a sinus bradycardia? I would like to call this underlying rhythm a sinus rhythm, but I don't know if it's truly over 60 or not. I would have to try to march out and try to find P waves. But if you put on here a sinus brady because your heart rate is less than 60 beats a minute, I would be okay with that. If you want to put a sinus rhythm, you need to try to identify the P waves to prove that it is truly a sinus rhythm. But we're going to put sinus brady with bigeminal unifocal PVCs. That's a pretty big interpretation for this kind of strip right here. It doesn't look like there's a lot going on, but there really is. Notice how I identified exactly what was going on. I have a sinus brady, which means I can only find P waves that are less than 60 beats a minute. Bigeminal means that something is occurring every other beat, every other normal beat. Unifocal tells me that they are all the same morphology, all the anomalies are the same morphology, and the PVCs identify what exactly the anomaly is. If you put in my class a sinus brady with PVCs, you're going to lose points. You have to put bigeminal. If there is a pattern, you need to put what kind of pattern it is. So don't put this. Put that right there. In this rhythm here, we're going to look at the atrial rate, which is 1, 2, 3, 4. It looks to be about 40, 300, 150, 175. Actually, these are occurring about 75 beats a minute, not 40, but we're going to pretend that this is a 6-second strip and go ahead and go with it. So we're going to say the atrial rate is 40 beats per minute. The ventricular rate is 1, 2, 3, 4, 5, 6. 60 beats per minute. This would definitely be a rhythm I'd rather do a range, but we're not going to do that for time. Regularity. This is another one of these rhythms where I wish I had a longer strip. I have a normal beat, PVC, normal, PVC. So it would be correct to put irregular. Would it be more correct to put something else? Yes, it would. It would be more correct to put regularly irregular, because we seem to have a pattern. P waves, when they occur, are present and married, except at the PVCs, because there are no P waves in the PVCs. PR interval is about 0.16 second. QRSs, normal QRS is about 0.08 second. The wide one here, these are a little bit tougher. So this will begin right here. This will end right about there. So that looks to be almost 0.16. So the PVC is about 0.18 second because it looks like it goes a little further past that box right there. The interpretation, what is our underlying rhythm? Our underlying rhythm could be 70 beats a minute. These arrows right here are pointing towards all of these little bumps right here. If you were to march these out, those would probably be P waves. So you could count those as P waves. The concern I have is that if you didn't have all these nice little arrows to point this stuff out, would you still be able to identify all those little arrows to point out all those little bumps? I would probably feel more comfortable by saying just go ahead and leave it the way it is and say, let's say the heart rate is 40 beats a minute. So we're going to say that this is a sinus Brady with, we have a PVC which occurs, looks like every third beat. So we're going to say with trigeminal unifocal PVCs. You can put unifocal, they're trigeminal, so they're occurring every third beat. They're unifocal because they all have the same morphology. They're PVCs, and that's what the anomaly itself is. In this rhythm, we have an atrial rate of 1, 2, 3, 4, 5. So we have an atrial rate of about 50 beats per minute. We have a ventricular rate of 1, 2, 3, 4. Count the PVCs. 5, 6, 7. Regularity. There is no patterned irregularity here, so this is just going to be straight up irregular. P waves. They are present and they are married, except at the PVCs. PR interval, when they occur, they appear to be about 0.20 second. So they look a little bit wider than they should be. QRS complex, the normal QRS looks to be about 0.08. Over here, though, they look to be a little bit wider. So it goes from there to there. So that's about, at the PVC, they're about 0.12 second. What is my underlying rhythm? My underlying rhythm is going to be a sinus Brady. But what do we have? We have a unifocal couplet. And if you just want to be fancy, you can put PVCs. Just to be fancy. Usually if you say couplet, people automatically know that you're identifying it as a couplet. PVCs, you don't call it a couplet PJCs. You can, but usually when you say couplets and triplets and salvos, they're talking about ventricular anomalies. So this is a unifocal couplet. How do I know it's unifocal? Take a look down here at your PVCs and you will see that the PVCs are virtually the exact same morphology. That tells me that these PVCs here are coming from the same ectopic focus. This one's a little bit more complicated, but let's take it one step at a time. What is my atrial rate? 1, 2, 3, 4, 5, 6, 7. My ventricular rate, 1, 2, 3, 4. That looks like a 5 right there. 6, 7, 8, 9, 10, 11. So our ventricular rate is quite a bit more than the atrial rate. Regularity, there's no pattern here. P waves. When the P waves occur, they are married to those QRSs. So they're present and married except at the PVCs. PR intervals, when they occur, they look to be nice and clean. So this one here looks to be 3, 4, so it's about 0.16 second for the PR interval. QRS complexes, under the normal situation, these look a little bit wide. So there's a really good opportunity here to do a 12 lead and see why this is slurring out right here. So the QRSs are 0.12 second. The PVCs are probably right about the same. So this one looks pretty wide. So we have it starting about here, ending about here. That's 0.16. So we'll just say 0.16. What we have here is the book was nice enough to show us all these red dots here are your P waves, all these blue dots here are your QRSs, or the ventricular depolarization. What it shows here is that there was supposed to be something right here and there wasn't. This right here is a P wave, and if you were to march it out, you would see perfectly that it would be a P wave. This right here is a QRS complex that occurs despite this PVC right here. What is the underlying rhythm? The underlying rhythm is still going to be a sinus rhythm. Unfortunately, this particular rhythm is not as simple as PVCs because we have a couple different things going on here. So this rhythm is a sinus rhythm with, I would probably call this a unifocal couplet because they're both traveling in the same direction and they both have the same T-wave morphology. There might be somebody else who might call that multifocal. So that's kind of where you need to do a 12 lead and hope that you can capture this again to see if it is truly a unifocal depolarization or a multifocal depolarization. For now, I'm going to go ahead and call this a sinus rhythm with a unifocal couplet and an isolated unifocal PVC. Big interpretation. The reason I put all this information down is because if you were to lose this rhythm strip, or if something happens and all you have is the interpretation, and your clinical director, or even worse, if you're at a deposition or in a court hearing, they say, can you identify and describe to me a sinus rhythm with a unifocal couplet and an isolated unifocal PVC, you would be able to do that. Moving on. This rhythm here, this is the last one, and then we'll move on to something else. Here is your P wave way out here. So we have a P wave, so there's 1, 2. This is a P wave right here, but without this red dot right here identifying that, would you be able to identify it? And I don't know if the answer would be yes or no. It would be great to be able to identify that, but it would be tough. So I'm just going to count the P waves on the QRSs themselves. 1, 2, 3, 4, 5. If I use the I know those are P waves idea, then it would be 50 beats per minute. If I use the red dot thing, because the book was nice enough to identify the P waves, then it would be 1, 2, 3, 4, 5, 6, 7, 8. It would be 80 if I were to use the book. The ventricular rate, 1, 2, 3, 4, 5, 6, 7, 8. 80 beats a minute. So let's look at the regularity. There's no pattern to this irregularity here, so we're just going to call it irregular. P waves. When we see P waves, they are present and they are married, but they are not present and married at the PVCs. PR intervals. This is a very wide PR interval. I don't like this strip right now in this presentation because this is showing another anomaly that we haven't covered as of yet. So I'm going to go ahead and just say the PR interval, as you can see here, is 24 maybe? 0.24? Yeah. We'll call it a 0.24 second. Now this is wide. In future presentations you're going to learn that this is a first degree heart block. But if you don't know what that is, don't worry about it right now. Watch the heart block presentation video. QRS complexes. This right here is kind of a weird, funky looking QRS complex. Unfortunately, this whole thing is the QRS complex. So that QRS complex starts out here and ends over here. So that QRS complex is 0.20 second. The PVCs look a little bit more narrow, but the PVCs are 0.12 second. Doesn't mean anything. It just means the normal depolarization of the ventricles is not correct. What would be my underlying rhythm? My underlying rhythm would be a sinus bradycardia, or if you could identify all of the sinus beats, all the P waves in there, then you could call it a sinus rhythm, but you need to identify them. Sinus brady with a PVC, and here's where it gets weird. This right here is a PVC. The book I got this out of said that is also a PVC. So what happens when you have two PVCs in a row? You have a couplet. Are those PVCs the same morphology? Not even a little bit. So you would call this a multifocal couplet. Let's move on to ventricular escape complexes, idioventricular and accelerated idioventricular rhythms. In a ventricular escape complex, the key here is it's ventricular, so you know it occurs in the ventricles. The escape complex means that it occurs what? That would be after the expected R to R interval. So what happens is you have your R to R interval here, so you have a QRS here. There is no QRS here, so your ventricle decided to depolarize to avoid ventricular standstill, to avoid the decrease in cardiac output. What happens here is because it occurs late in the cardiac cycle, it is considered an escape interval. What happened after this ventricular escape complex? You pick back up to a normal sinus rhythm. That would be an example of a ventricular escape complex. In this case, we have a sinus rhythm or a sinus beat and a sinus beat. We have the expected next beat right here, and it doesn't occur. So what happens is the ventricle takes over, but the SA node did not pick up again, so it threw another ventricular escape complex. The idioventricular rhythm is when the Purkinje network, or the Purkinje fibers, it's the same thing, takes over as the primary pacemaker of the heart. It's a tertiary pacemaker, but it takes over as the pacemaker. The Purkinje network have an intrinsic rate of 20 to 40 beats per minute. It initiates to avoid cardiac standstill and going into asystole, and it can be very common during cardiac arrest, usually as the first rhythm after cardioversion, or in this case unsynchronized cardioversion, which is also called defibrillation. So a lot of times the idioventricular rhythm is the first organized rhythm after defibrillation. It could be perfusing or non-perfusing. Most of the time right after defibrillation it is non-perfusing. Idioventricular rhythms have a significantly decreased cardiac output, or sometimes they actually have an absent cardiac output. Sometimes if you have a heartbeat of less than 10 beats a minute, it's considered agonal. Agonal rhythms are usually indications of a dying heart. There's no cardiac output, and like I said, you can abbreviate idioventricular as IVR. Some of the characteristics of an idioventricular rhythm, usually 20 to 40 beats a minute. It can be very regular. It can be irregular, but most of the time is classified as regular. It can have a P wave, but most of the time the P waves are absent, because if you're in an idioventricular rhythm, the heart has suffered some kind of a traumatic event, usually a heart attack of some kind, and the SA node is not doing its job. That's why the patient is in an idioventricular rhythm. If there are P waves, they will be dissociated, which means you will have no association between the P waves and the QRS complex. Since there's no P wave, there would be no P to QRS ratio, and since there's no P waves, there would be no PR interval. QRS width in an idioventricular rhythm, though, is always going to be wide. What I mean by P wave dissociation in idioventricular rhythm, and this will learn later is a different type of rhythm, but this is what I mean. If there's P waves and the QRSs are not occurring because of the P waves. Later you'll learn that this is a specific kind of heart block, but this is what I mean by atrioventricular dissociation. Accelerated idioventricular rhythm just is abbreviated AIVR. That just means that the heart rate is above 40. So IVR, the heart rate is 20 to 40 beats per minute. Accelerated idioventricular is 40 to 100. What happens if the heart rate in an idioventricular rhythm is greater than 100? Well, any heart rate that is greater than 100 is tachycardia. And if it originates in the ventricle, it's ventricular tachycardia because the heart rate's over 100. That's why AIVR only goes up to 100. The heart rate for idioventricular rhythm is 40 to 100 beats a minute. Typically, these are very regular rhythms. They can be irregular, but typically they're very irregular. The P waves are usually absent because if you have a P wave, normally the heart should be beating on its own in a more organized rhythm. But it can be dissociated if it is present. If there's no P wave, it's no P to QRS ratio, and if there's no P wave, there's going to be no PR interval. Idioventricular rhythms are usually wide because they come from the Purkinje network, and it causes the QRS to be extremely wide. If we were to look at some rhythms here, we would identify this as what is our atrial rate? Well, we don't know. What this is showing here, this arrow here, is showing a possible P wave back here. But would you be able to identify that without having that nice little identifier there? I don't think you would. I wouldn't. So we're just going to go ahead and pretend that this extra little weird thing back here could just be some artifact, or it could be some after depolarization that we can't identify. So we're not going to identify those as P waves right now. Our atrial rate would be unable to obtain. Ventricular rate, if we were to use the 6-second strip, if this were a true 6-second strip, we would call it a 40 beats per minute. We can do the actual calculations, but we'll just say it's a 40 beats per minute. Regularity, if I had calipers and marched it out, I'm betting that these would be regular. P waves are absent. PR interval, you can't have a PR interval if you don't have a P wave. The QRSs are a little wide, so we're going to start right there. We're going to end right there, so maybe that's 0.12 second. In this case, this is a wide, bizarre-looking QRS, and we're talking about ventricular rhythm, so we're going to go ahead and call this, we can call it AIVR, or we can call it IVR, because 40 is kind of that borderline gray area right there. So it could be accelerated, it could be idioventricular. If you want to calculate the true rate of the ventricle, I'm sure it wouldn't be exactly 40. It would be a little above or a little below so that you can identify exactly if it's IVR or AIVR. The next one here, that's a pretty wide and bizarre looking rhythm. Hopefully your patient's not in that. Atrial rate, unable to obtain. Ventricular rate, we're going to say is 50 if this is a true 6-second strip. Regularity, it looks regular. If it's not, and in putting regular, like I said, I don't have calipers. P waves are absent. PR interval is none, since we don't have any P waves. QRS complex, this one's a little bit wider, so they're a little harder to tell. So starts here, ends here. Looks like it starts here, ends here. This one has a little weird thing in front of it. Starts there, ends there. So we're going to say it looks like it's about 0.20 second. 50 beats a minute would put that where? It would probably put that in the 40 to 100 range, which would be accelerated idioventricular rhythm. This one is pretty much just like the last one. Atrial rate is unable to obtain. Ventricular rate looks like it's 1, 2, 3, 4, 5, so we'll say it's also 50 beats per minute. Regularity is going to be regular. P waves are absent. PR interval none, since we don't have P waves. And the QRS complex, pretty wide here. So we're gonna, the QRS, see how it kind of goes up first and then down, and ooh, there's a notching right there. We'll talk about that in a second. But see how it goes up and then down? That's where it begins, is right there, ending right about there. So this looks like it's 1, 2, 3, 4, 5, maybe 6 little boxes. So QRS is 0.20 second. Whoops. 0.24 second. My mistake. Interpretation is 50 beats a minute, so we're going to say that it is accelerated idioventricular rhythm. Just a second ago I said something about that notching on the way down. One of the things that people use to identify this as a true ventricular rhythm that originates in the ventricle is something called Josephson's sign. Josephson's sign is this notching as you go down, this notching, and then it goes back up. It goes down and it notches and it goes back up. That is a Josephson's sign that usually indicates that this is originating in the ventricles and it is not a block in the ventricles. In the next rhythm, we have no P waves that we can identify, so we're going to say the atrial rate is unable to obtain. Ventricular rate, 1, 2, 3, 4, 5, 6, 7. So the ventricular rate will be 70 beats per minute. Regularity, it looks regular. The P waves are absent. PR interval, none. QRS complex is wide. It starts over here and ends down here. So we're going to say it's about 0.12 maybe. 0.12 second. Since it's 70 beats a minute, we're going to go ahead and say that this is accelerated idioventricular rhythm. This rhythm here, we're going to try to identify P waves, and this is not a P wave right here, just to let you know. That might look like a P wave, it is not a P wave. So we will say that the atrial rate is unable to obtain. The ventricular rate is 1, 2, 3, 4, 5, 6, 7, 8 is 80 beats per minute. The regularity is going to be regular. P waves absent. PR interval none. QRS complexes, this is a good one. This is a really big QRS complex. It starts right here just as you start to have that little dip before it goes down like that. So it starts right there. And the QRS might not end up here because technically that's the top of your T wave. The QRS technically ends all the way down here. So in this case, the QRS looks to be just about 0.20 second. It might be a little bit less than that. Actually, it does look a little bit less than that, but that's where you would identify the QRS. You can't go from here to here because you just don't go straight across. Interpretation in this case, 80 beats a minute, is an AIVR. In this one, we don't really identify any P waves, so the atrial rate is going to be unable to obtain. Ventricular rate, 1, 2, 3, 4, 5, 6, 7, 8, 9. So it's 90 beats a minute. This rhythm is good to look at because there's a lot of weird bumps going on in there, and we can't identify anything that's going on. Fortunately, the book was able to identify the QRS for us. So this part here that goes down and then notches like that, that's the QRS. This here goes into your T wave. Notice that this does not look like a normal T wave up here. I'm betting that there is a P wave somewhere up in there, but I would definitely want to do a 12 lead, and I would definitely not want to sit here and go, clearly there's a P wave, because we don't know. Regularity. It's going to be regular. P waves, I'm going to say that they're absent, which means a PR interval, there isn't one. QRS complexes, it's showing us the QRS. So the QRS looks like it begins right here and it ends right up here. So I'm going to say that that's our QRS complex, and what is that? 0.16 second. Since it's 90 beats a minute, unless we do the actual math, 300, 150, 100. So it might be pushing more of 100, but I'm going to stick with 90 and call it AIVR. Last rhythm, atrial rate, unable to obtain. Ventricular rate is 1, 2, 3, 4, 5, 6, 7, 8. Regularity is regular. P waves are absent. PR interval is none. QRS complex. In this one, it's a little bit easier to tell the QRS. It begins there, it ends right there, so it looks like it's about 0.16 second. Since it's 80 beats a minute, I will go ahead and say that this is AIVR. Next, we're going to discuss ventricular tachycardias. In the past, it has been thought and taught that all wide complex tachycardias are ventricular until proven otherwise, which means all wide complex tachycardias should always be treated as ventricular tachycardia, period. They should all be treated that way because it was thought that if you treated it any other way, you would potentially kill the patient and make the rhythm worse. This is not true anymore. Now, with better pharmacology and diagnostic tools and the information we have, not all wide complex tachycardias are ventricular in nature until proven otherwise. It is possible for you to have a supraventricular tachycardia with an aberrancy that you can treat as supraventricular. In some cases, with a regular, stable, wide complex tachycardia, you can give adenosine to try to suppress the arrhythmia. You could have a supraventricular tachycardia with an aberrantly conducted QRS complex, which is something that I cover in the junctional presentation. You could also have some kind of interventricular conduction delay like a bundle branch block. And if you have a supraventricular tachycardia with a left bundle branch block, it's going to look a lot like VTAC. But you wouldn't treat it as VTAC, you would treat it as a supraventricular problem. Let's go ahead and talk about VTAC though. Ventricular tachycardia occurs when there are 3 or more PVCs in a row. That is what classifies VTAC. Some people refer to those as triplets or salvos. So sometimes 3 PVCs in a row will be called a triplet. Sometimes people will refer to it as a salvo, as salvos, to just kind of identify that. Those are some older terms. Realistically though, if it's over 3 beats a minute, it's VTAC. What is considered sustained versus non-sustained? Depending on the text you read, sustained VTAC occurs if the VTAC here occurs over 30 seconds. If it goes over 30 seconds, it is considered sustained. If it is under 30 seconds, it is considered non-sustained VTAC. This is primarily for documentation purposes. If you have a 25-second run of VTAC, you probably need to treat the patient the same way as you would if it was over 30 seconds. Ventricular tachycardia could occur with or without pulses. It is possible for somebody to have a wide complex tachycardia and still have a pulse. It is abbreviated as VT or VTAC. You can abbreviate them both ways. That's appropriate. There is usually a loss of the atrial kick. If you remember, the atrial kick usually accounts for about 20 to 30% of ventricular filling. What we do though is we call that preload. If VTach is not treated aggressively, it will potentially deteriorate into something that is more like a VFib or even asystole if it's not treated aggressively. What causes VTach? Well, the first one, the ones that we've covered before, reentry circuits, and we're going to discuss that again here in a second. Another possible mechanism is something called an increased automaticity. Increased automaticity just means that the cells are more irritable, and something else called after depolarization. So we're going to talk about each one of these. First, let's review the reentry circuit. The reentry circuit occurs if three specific criteria are met. First of all, you have to have two separate pathways. Each pathway has to have a different underlying property, which causes one of the pathways to have a slower conduction. How does the heart in the ventricle develop two separate pathways with two different properties with one slowing property in the ventricle? Sometimes what will happen is people will have some heart attack of some kind. When somebody has a heart attack, and we're going to look at this right here, this part down here is the endocardium. Out here is the epicardium. To make it easier, this is superficial. This is deep. So this is deeper into the tissue. As the person has the blood vessels get deeper into the tissue closer to the endocardium, more collateral circulation occurs the deeper that you go into the myocardial muscle. If it was this artery that was blocked right here, the deeper you go, the more collateral circulation you get from adjoining arteries, from arteries that were just on either side of the artery that was blocked. What that does is it creates this wedge going down into the endocardium, this wedge of ischemia. It doesn't go straight down, it actually goes in towards like that. It's because of the circulation and the collateral circulation. Although this artery was completely blocked, the two collateral arteries here, as you can see here, kept this area of the tissue perfused. So that area of the tissue is now still able to conduct electricity. It is still viable. What that does is it creates this tube of conductive cells, or this tunnel of conductive cells through here. This is a 2D, so if you were to take it to a three-dimensional picture, this is kind of what it looks like. Here's the collateral circulation going through right here. So you have this area of tissue here that is still viable and still able to conduct electricity. The problem you run into is the electricity and the impulses that are going to try to get through this tube right here are going to go much slower because there are a lot less cells able to conduct the electricity. So you're going to have a slowing of the conduction. So now we have different properties. What happens here is the tube through here contains less gap junctions. Gap junctions are very important. Those are like the little relay stations between each of the myocardial cells and the intercalated discs. Because of that, the signal goes much slower because there are less gap junctions to transmit that impulse through there. This causes the different properties of the different cells. Because of that, here's your tube, here's your slowing through the tube. You don't have as many cells that are able to conduct that electricity. So therefore, the signal does not have a normal massive depolarization wave rifling through there. It goes much slower. The area of slowing can actually cause a problem. Now, most of the time, when you have this normal impulse come down through here, you have the slowing going through this tube right here. This impulse is going to travel through here much more quickly, and it's going to try to travel back upwards up this tube right here. If you remember what happened with the AV node and the SA node and the fast versus the slow tract, it's very simple. Or it's very similar, I'm sorry. These two signals will meet each other and cancel each other out. But if you remember what caused the person in that situation in the junctional rhythm presentation, what caused that person to have that reentry circuit begin It was a PAC. Well, here we're talking about the ventricles. So what do you think would cause a micro reentry circuit in the ventricles? A PVC. So you have this normal sinus rhythm here, and this PVC right here could send somebody into this this ventricular tachycardia. How that would occur is if you had a PVC that occurred right here, the signal would travel down this area. It would also travel up this area as well, but it would travel down this area, go through this tube, and then it could very easily start a circus re-entry problem right here, causing somebody from that PVC to go into that ventricular tachycardia. The characteristics of ventricular tachycardia: the rate between 100 and 150 is usually classified as a slow VTach. It's not just regular ventricular tachycardia because it is a little bit slower. VTachs can go much, much faster. So if it's less than 150, sometimes it's called slow VTach. If it's over 150 to 300 and higher, it'll usually be called ventricular tachycardia or VTach. Usually it's very regular. P waves will usually be absent. Since they're absent, there's no P to QRS ratio, and because there's no P wave, there's not going to be any PR interval as well. VTachs are going to be ventricular in nature, so they're always going to be wide. Unfortunately, there are several different morphologies that you could develop with ventricular tachycardia. All of these could be classified as a VTach, even this one right here, which looks a little weird. Most of the time, VTachs are pretty clear. Usually they're these right here. A lot of times they will be something like that right there. If you see those morphologies, and you can pretty much assure that the person isn't a ventricular tachycardia. Like I said before, 3 or more PVCs in a row is considered a ventricular tachycardia. So in this case, we're going to just do a brief rhythm identification here because this is a really cool rhythm. You have a normal beat here and a normal beat here, and then what do we have? We have 1, 2, 3, 4 beat run of VTach. Normal beat, 1, 2, 3, 4 beat run of VTach. You could almost say that this is a patterned VTach. What initiates this run of VTach is a PVC. So let's look at this here. We have a sinus rhythm or sinus brady with trigeminal four beat runs of VTach. Notice that I didn't just put trigeminal VTach. If you just put VTach, it kind of leaves it a little bit ambiguous about what kind of ventricular tachycardia it is. Now, if I put a 4-beat run of VTach, that kind of paints the picture. So you're having 2 sinus beats, a 4-beat run of VTach, 2 sinus beats, and a 4-beat run of VTach. What if I said that that was a 14-beat run of VTach? That would probably change how you see the patient. So you're having 2 sinus beats and then a 14-beat run of VTach and then 2 sinus beats. But in this case, that's not it. It's just 4 beats. So that's why I like to put exactly how many beats of a run of VTach that it is, because it paints a clearer picture. Let's go ahead and look at this rhythm here. As you can see, that is a clear VTach. Atrial rate is unable to obtain. The ventricular rate, you can usually just do between 2 PVCs like that, or you can do the 6-second method. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18, 19. So we'll say this is a 190 beat per minute for the ventricular rate. Regularity is going to be regular. P waves are absent. PR interval is none. QRS complex. This is where it's going to get weird because it's really hard to identify where the QRSs are in a lot of these VTachs. Understand, though, that the QRS does not start here and end here. It does not start here and end here. Those are not the QRSs. You have to kind of identify somewhere in here is where the QRS starts. So let's just say that that's your beginning and that's your ending right there. That's going to be about a 0.12 second. How do you identify this interpretation? You would not be wrong if you just said it was VTach. Personally, I like to call it a sustained VTach. I don't have a 30-second strip here, but it's clear to me this is a sustained VTach according to this rhythm strip. Another one here, as you can see, it's going all the way across. This would be considered also a VTach, so the atrial rate is going to be unable to obtain. The ventricular rate, I calculated it previously, is actually a 135 beats per minute. Regularity is going to be regular. P waves are going to be absent. PR interval is going to be none. QRS complexes. Here's another one, really hard to tell. I identified this initially as there's the beginning of the QRS complex all the way down here. This is actually part of your T wave down here. So I actually stopped measuring right there. So to me, this came out to a 0.20 second QRS complex. Still very wide. Interpretation, you can call it a VTach. I personally call it sustained VTach. You could also identify this as slow VTach. Technically, it is less than 150 beats a minute, so it would be classified as a slow VTach. Atrial rate, well, let's look down here at this P wave, or I'm sorry, at this arrow right here. The arrow is probably pointing to a retrograde P wave. Are you going to be able to identify that? I would not be able to identify that, so I'm going to say that the atrial rate is unable to obtain. Ventricular rate that I calculated previously, the ventricular rate is 155 beats per minute. Regularity is going to be regular. P wave, like I said, I'm going to consider it absent because I would not have been able to identify that P wave in there. PR interval is going to be none. QRS complex looks wide, starts right here, ends way over here, so it's going to be 0.16 second. The interpretation, sustained VTach, and it's not slow because it's over 150. On this rhythm here, we have an atrial rate of unable to obtain because we don't see any P waves at all. The ventricular rate is going to be, as I calculated it earlier, is 115 beats per minute. Regularity is going to be regular. P wave is absent. PR interval is none. The QRS complex, kind of hard to tell on this one too, begins over here. Looks like that this is your T wave and ST segment. There's an extra little bump in there. That's kind of interesting. I'd like to see this guy's 12 lead. Ends right here, so I would say that would be a 0.18 second. And my interpretation is going to be sustained. Look at your heart rate. Slow VTach. In this rhythm here, once again, we have this little arrow right here that is showing us a retrograde P wave. Would I be able to identify that? Yeah, probably not. So I'm going to say that that's just some kind of anomaly right there that I wouldn't be able to identify at this time. So I'm going to identify this as an atrial rate, an unable to obtain. Ventricular rate. The ventricular rate that I calculated earlier was 115 beats per minute. Regularity is going to be regular. P waves are going to be absent. PR interval is going to be none. QRS complex, to determining the QRS width, this is where it would begin just right about halfway through that box and it would end right down here. In this case, the QRS width looks to be about 0.12 second. Interpretation, sustained, slow because of the heart rate, VTach. I really like this 12 lead right here, or this rhythm right here. This is the last one, and then we'll move on. What is my atrial rate? This is pretty cool because we do have an atrial rate over here. Now our atrial rate up to this point is different than what we would calculate for the whole strip. So if you were just to calculate the atrial rate up to this point, you could say it's 300, 150, 100, maybe about 90. So if you use that, you can say it's about not 99. It's about 90 beats per minute before the VTach. Or you could just put 30 beats per minute because that's exactly what it is. It's supposed to be an A with a line over it. That's before. The ventricular rate is going to be 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. So you could say that's about 100 beats per minute. The regularity is going to be irregular. This part here is regular with itself. There's a PVC. This part here is regular to itself. But if you start at the front of the strip and go all the way to the back of the strip, guess what? It is all irregular. P waves, present and married until the VTach, and then it's absent. PR interval up here is about 0.16 second. Up here, the QRS is 0.16 second to absent, if you want. QRSs over here are 0.08 second. And then what happens over here at the PVCs? It goes up to about 0.12 second. Maybe even wider. Over here it looks a little bit wider. The interpretation of this is a little bit more complicated because you have to identify everything that occurs in this. What is going on over here first on the front side of the strip? You have a sinus rhythm. And then what happened? A PVC occurred. And then it went into a sustained VTach. This would clearly define exactly what's going on this rhythm. A sinus rhythm with a PVC into a sustained VTach. Polymorphic VTachs. Polymorphic VTach is an umbrella term which describes a ventricular tachycardia that is not regular. So it is an irregular grouping of ventricular tachycardia. It can originate with an R on T phenomenon, and we talked about the R on T's before. That's a view of what an R on T might look like. And it is a rhythm with normal QT intervals. And then it goes into a polymorphic VTach. This is a specific polymorphic VTach, which we'll talk about in a minute. But let's just talk about polymorphic VTach first. A specific polymorphic VTach is something that we call torsades. I don't speak a foreign language like French or anything like that, so I would probably Americanize this really badly by saying torsade de points, but anyway, it's called torsades. A lot of people just call it torsades. Torsades is a very specific type of polymorphic VTach. And the torsades, what happens is, if you see the points down here of these QRSs, what happens is it switches, and now you have points of QRSs going up. So here you have kind of a rounding of the QRS, and then the points are now twisting this way, which means now you have kind of a rounding going down here while the points are up here. That is the twisting of points, or the torsades is what it is. Just understand that torsades is a specific polymorphic VTach. You can have a polymorphic VTach but not be in torsades. So polymorphic VTach, talking about this, a unique type of polymorphic VTach is called torsades. The QRSs will alternate between upright and downward deflections, so you'll have the points going this way, and I'm just going to try to draw it here, and then it'll get smaller, and then it'll start to get big again, and then the points will be going that way, kind of. So you'll have is these twisting of points. What they have found is that if you can identify polymorphic VTAC, specifically torsades, your next antiarrhythmic is magnesium sulfate. You don't give amiodarone or lidocaine, you immediately give magnesium. Once again, torsades has a lot of the same and similar types of characteristics as VTAC. You have a heart rate there of 100 to 150 is slow. It's all the same. 150 to 300 is considered just regular polymorphic VTAC. It's not usually regular. That's actually wrong. Usually it's irregular. The P waves are usually absent. Since they're absent, there's not going to be any P-QRS ratio, and because of that, there's not going to be any kind of PR interval. Let's identify a couple of these. Here, this is a picture of a torsades. The atrial rate is going to be unable to obtain. The ventricular rate is a little bit harder to determine. You can just use the 6-second method and just count them and put a 0 behind the number. Or what you can do is take a range of between the widest and narrowest R-to-R intervals and calculate them that way. For simplicity's sake, let's just talk about just doing the 6-second method. So we have about a heart rate of 210 beats per minute. Regularity, it's going to be irregular. P waves are absent. PR interval, none. QRS complexes, this is going to be really hard to identify the QRS complexes. It really is. This one, that might be the beginning, that might be the end right there. Maybe that's the beginning, maybe that's the end. If you do something like that, you can say it's 0.16 second. You have to put a number in here somewhere whenever you do my homework. You can't just put wide. If you just put wide, it'll be wrong and you'll be losing a point. Interpretation basically is going to be torsades. If you look at this, you can kind of see the undulating of the QRS morphologies. You see how it kind of gets bigger, then it gets smaller. It gets bigger, then it gets smaller, then it gets bigger again. Like that. You can kind of identify the twisting of points, and it's a little harder to identify in some of these, but like here's your points are up here, and then you can kind of see your points moving down here a little bit. Maybe they're up here. It's kind of tough to tell. Anyway, this would be an example of a torsades. I have a really good example for you on the next slide, though. In this one, this is a really good picture of a torsades. So we're going to say the atrial rate is unable to obtain. The ventricular rate is 180. Regularity is going to be irregular. P waves are absent. PR interval is none. QRS complexes, really hard to measure these. It really is. That looks like that might be right there to right there. That might be a good one. So I'm going to say maybe this one to this one. 0.16 second when we can identify it. Interpretation, this is another. This one's really cool because you can see the points down here and you see how they kind of switch, and now the points are up here and the curves are down here and the curves are over here and they're up there. So what's going to happen is it's going to start doing this again, and as it heads down in this direction, it's going to come from here and it's just going to start doing this again, and it's going to keep flipping like that. Here is another torsades patient. So we're going to look at the atrial rate, which is unable to obtain. The ventricular rate is about 250 beats per minute. Regularity is going to be irregular. P waves are absent. PR interval is none. QRS complexes, once again, really tough to tell. You have to kind of try to identify them. That looks like it from there to there, maybe. 0.12 second. Interpretation. Notice the undulating here, the bigger, the smaller, the bigger, the smaller, how it kind of, you have kind of the bigger one, then it goes the smaller one, just like that. This one's kind of weird because it goes real big, real small, really fast here, but it's still considered a torsades. It's not really easily identifiable of the twisting of points. It looks like we have a little bit over here. There's your points, and then that might be your points up there. Anyway, it's torsades. On this one here, we have an atrial rate, and what's interesting is we have a P wave right here, and what we have right here looks to be an R on T PVC. There's a P wave with a sinus beat, and there's an R on T PVC. So it looks like that the heart is really irritated at this point. So we have what looks to be an atrial rate at this point of 20 beats per minute. But if you try to do the calculations, 300, 150, 175, 60, so we'll say just for fun, 55 beats per minute before the VTach. Our ventricular rate, 1, 2, 3, 4, and then it goes into this whole thing here. Looks to be for the whole strip about 230 beats per minute, but that's for the whole strip, including this area right here. You can do a separate ventricular rate over here for just these, and then into that. It's kind of how you feel like you want to document this. Regularity is irregular. P waves are going to be present and married, except at ventricular ectopy / VTach. PR intervals, when they're present, they look to be about 0.16 second. QRS complexes, when they're normal, looks to be about 0.08 seconds. So they look normal until you get into the PVCs and the VTach. The difficult part is how do you interpret this rhythm? Because there's a lot of going on this rhythm here. The underlying rhythm looks to be about a sinus bradycardia. Even if I use this right here as what happened before the VTach, I'm still at about a 55 heart rate. So I have a sinus bradycardia with unifocal, bigeminal, R on T PVCs that goes into, this might be a torsades, but to me it might also be a polymorphic VTach. The book called that a torsades, but we're going to go ahead and call it, it goes into a polymorphic VTach. Now let's talk a little bit about a ventricular fibrillation. Ventricular fibrillation occurs whenever there is a chaotic firing of multiple ectopic foci in the ventricles themselves. This isn't one or two spots, this is multiple spots in the ventricles, all trying to be the ventricular pacemaker. This causes the muscle, the cardiac muscle, we're talking about the myocardium here, to quiver rather than contract. So basically, if you were to take a bowl of Jello or something and put it onto a table and hit the table and it just sits there and quivers, that's basically what's going on. It's just sitting there quivering. Within seconds, in a VFib, the cardiac output drops to 0. It does not take long. Once you go into a VFib like that, your cardiac output plummets. Most common causes of cardiac arrest in the pre-hospital setting is VFib. So the characteristics of VFib, the atrial rate and the ventricular rate is not measurable. There is no way to measure it. The regularity is irregular. There are no P waves, so there's no P to QRS interval, and there's no P to Q at all. The QRS width, you can't measure it because there are multiple QRSs all buried within each other. So the mechanism behind VFib, if you look at a little area right here, what happens is you can end up in a re-entry circuit here, but each one of these stars is an attempt to depolarize the ventricle. Each one of those stars is a depolarization that the monitor picks up, and as you can see here, there is no organized activity whatsoever. Without organized activity, you have no cardiac output. So because you have all of this disorganized activity showing all of this VFib stuff right here, The purpose of defibrillation, and if you look at the word itself, you're defibrillating. You're trying to stop the fibrillation. When shocking the heart was brand new, and I think it started way back in the 50s, I think, is when it started. What they were doing is they were doing this in surgery so that when the heart in surgery, when they had the heart open and they could see it, it would start quivering like this. They would take these little paddles, these little metal discs that were attached to these long handles, and they would stick them directly on the heart, and they would send a bolt of electricity through the heart to try to stop the fibrillation process. What happens is, because of all of this erratic activity, when you defibrillate or shock somebody, you cause all of that electrical activity to stop depolarizing at its own time. You depolarize everything all at once. In the perfect world, what would happen is then the SA node would take over and you would go into a normal sinus rhythm because the SA node wouldn't be suppressed anymore. In this rhythm here, we need to look at what kind of VFib this is. It looks like a VFib. Do we have an atrial rate? No, this is unable to obtain. VFib, can we get a heart rate off of this? Can we get a ventricular rate? Ideally, no, we can't. So in this case, it's going to be an unable to obtain this one. Regular, still have to put irregular. P wave, none. PR interval, none. QRS complex, unable to obtain. Why is the QRS complex unable to obtain? Because there are multiple QRSs buried within each other in there, so there's no way to determine which one of those is truly the QRS depolarization. Interpretation, this is going to be called coarse VFib, because you can also have a fine VFib. So if you just identify this as VFib, you'll be okay. But ideally, this is coarse VFib. Here would be another one where the atrial rate is unable to obtain. The ventricular rate, unable to obtain. Regularity is going to be irregular. P wave is absent. PR interval is absent. QRS complex is unable to obtain. This would also be an interpretation. If you just put VFib, you would be fine, but you could also put coarse VFib. In this one here, what we're looking at is this blue arrow right here is actually showing what each one of these blue dots are identifying right here. Not really sure what those are. Those could be QRSs, and this could all be artifact, or this could just be the little blue dots. These little sharp points are the artifact, and the underlying rhythm is VFib. Can't really tell. The book didn't identify them either way. It was in the ventricular fibrillation section, so I'm assuming it's VFib. So the atrial rate is unable to obtain. The ventricular rate is unable to obtain. Regularity is going to be irregular. P waves are absent. PR interval, absent or none. Either one is fine. QRS complex, well, we can't get a solid QRS in there. Interpretation, this would also be coarse VFib. The atrial rate is unable to obtain. Ventricular rate, unable to obtain. Regularity is irregular. P waves are absent. PR interval is absent. QRS complex is unable to obtain. This would be an example of fine VFib. You could also just call this VFib. If you do get this rhythm on my homework, just understand that if you put this as asystole, you will be marked off. It is not asystole. You see all these little bumps down here? That is not asystole. That is cardiac activity, which we need to try to stimulate. Speaking of asystole, let's talk about asystole. Asystole is the absence of any cardiac activity whatsoever. This is the last rhythm and the only rhythm that people will ever be in. We joke about it and say it is the most stable rhythm because you can't get any worse, you can only get better. But if a person is in asystole, they have had lots of cardiac issues they've been in a VFib and a VTAC for an extended period of time. Very commonly follows VTAC, VFib, pulseless electrical activities, which we'll talk about, and of course agonal rhythms. Also known as flatline, so when you see someone, oh my god, they're flatlining, that usually means the person is in asystole. Recovery from asystole is extremely low. We're talking fractions of a percentile, but it is possible to have some kind of a heart rhythm, regularity, and everything after a person has been in asystole. It's just not very common. The characteristics of asystole, of course, the heart rate is 0 beats a minute for the atrial and the ventricular. Regularity, you can't measure it because there's nothing to measure. It's just a flat line. P waves are going to be absent, no P to QRS ratio, no PR interval, and of course the QRS width is going to be none because you don't have a QRS to measure. This is an example of an agonal beat, so let's look at this. The atrial rate is unable to obtain. Ventricular rate, if you really wanted to call it that, you could call it 10 beats per minute if you want to use the 6-second method. Regularity, well, you only have one beat. How are you going to measure regularity with only one beat? So regularity is unable to obtain. P waves, there's none. PR interval, there's none. QRS complex, if you really wanted to measure this QRS complex, you could probably start there and end right there. So we're going to say 0.40 second. Interpretation, this would be an agonal complex into asystole. Here's another one. I don't like this one much as asystole because this might show some kind of ventricular activity, but the book is calling it asystole, so that's what we'll go with. How do you document this one? Atrial rate, none or unable to obtain. Ventricular rate, unable to obtain. Regularity is none. P waves, none. PR interval, none. QRS complex, you can put unable to obtain. Interpretation, asystole. Asystole differs from something called ventricular standstill. Ventricular standstill and asystole differ because in ventricular standstill you have P waves. You do not have QRS complexes, but as you can see here, there are P waves, which means the heart is not completely dead yet. So, in this case, in my class, if you call this asystole, you will be marked off for it because it is ventricular standstill. Pulseless electrical activity. This is another rhythm or condition that I would like to discuss in this situation, and there are a lot of people who get confused about what this is, but hopefully I will be able to clear that up. Pulseless electrical activity, a lot of times people will call it a specific rhythm. Pulseless electrical activity is not a rhythm. It is not a rhythm. Pulseless electrical activity is a patient condition. It is a condition the patient is in, not a specific rhythm. The reason I say that is because for a person to be in a PEA, there is electrical activity but no mechanical activity, which means the electrical activity should have a pulse. Now, VFib is not PEA because you're not supposed to have a pulse with VFib. Okay? What happens if you have, let's just make something up, which is how about a sinus rhythm at, we'll say, 30 beats per minute. Should this right here have a pulse? Yes, it should. If this does not have a pulse, then the patient is now in a PEA, which is a condition. PEA, not a rhythm. Let's talk about some causes of PEA. The American Heart Association uses something called the H's and T's, and there's several H's and there's several T's, which are what they call contributing factors to cause a pulseless electrical activity or any reason why a person is not responding to ACLS protocols. The old method that I learned way back in the day was something called the matched method. The matched method will hit all of your H's and T's. If you would like to know what the H's and T's are, please look them up online. I would like to discuss the matched method. The way the matched method works is we have your M, A, T, C, H, E, D. This is how I recall my contributing factors. The M stands for MI, myocardial infarction. The A is acidosis. The T tension pneumothorax. That will also cause a PEA. The C, cardiac, is cardiac tamponade. The H we'll get into in just a minute. It's a little bit more complicated, but generally speaking, it's the hypos and hypers. And we'll get into that in a minute. The E is embolism, specifically pulmonary. And the D is drug overdose. If you were to look at the H's and T's, you would cover all of these in the H's and T's. Let's talk about the hypers and hypos right quick. When I talk about hypers and hypos, what I mean is consider all of the glycemia, thermias, volemias, any of the electrolytes like natremias, calcemias, potassemias, or kalemias. It's actually not potassemias, but kalemias, potassium levels, oxemias. You just want to consider anything that would cause this to prevent the person from having a contraction with a rhythm that should have a pulse. So, can hypoglycemia cause it? Yes, it can. Hyperthermia, hypothermia can cause PEA. Hypovolemia can cause PEAs. Hyponatremia, hypernatremia, especially potassium problems, hyperkalemia or high potassium levels will cause PEAs. Hypoxia will cause PEAs. So when I talk about the hypers and hypos, it's just kind of that catch-all, things in the body that are extremely high or extremely low. I hope that you enjoyed the ventricular rhythm presentation. If you have any questions, please feel free to contact me or your instructor. Thank you.